Dear pure urology viewers, good evening one and all. Today we are discussing a good technique, that is enucleation of the prostate. Last 10 years, at least if I remember correctly, the enucleation has picked up. Bipolar enucleation was good, still somebody are doing, but as the lasers have come more and more, laser enucleation only most of the places discussed, most of the places practiced. However, there are two lasers. One is thulium fiber laser and holmium laser. There will be differences. I am using thulium fiber laser. I always feel that I need to do a little mechanical to see the capsule. And second thing, I have to touch the tissue to cut. These are two limitations. If I touch more to the tissue, it becomes brown. If I touch more to the capsule, it looks beautiful, but it will perforate. So it should be a very, very thin line, and that shoe with touch you have to cut. So technically it is becoming difficult for me. Chromium laser enucleation I don't have. I had 60 watts. With that, I used to feel that it was slow. So data 100 watts was very costly. 120 watts, no conflicts of interest. Luminous, this blast effect, what Moses effect has come, separate mission they made. And now 160 watts, two have come. One says that it is pure chromium. Another says that chromium plus thulium, which is useful for both the stones as well as the thulium fiber laser. So to talk about this, today's speaker is, in fact, is my close friend, Dr. Tanujpaul Bhatia, who is the chairman. I will introduce officially. Then I will hand over the program to him. Uh, uh, Dr. Tanujpaul Bhatia is for Faridabad is talking about high wattage laser, more than nearly 160 watts. Does it make a difference in HoLEP? The primary intention is that 120 itself is doing good job. Then why they have made 160 watts and what is his experience? So Dr. Tanujpaul Bhatia is chairman ILSS Hospitals Faridabad, which is again an independent hospital where the urology work is focused predominantly along with the surgical work. Areas of interest are HoLEP, RIRS, mini PCL, supine PCL, DCIRS. He is president now Haryana Urology Association. He got multiple awards: USA Sitaraman Memorial Essay Award 2012, Dr. Peter Gilling Best Laser Video Award AIE 2023, Luminous Best Laser Video Award USICON 2017, Daskan Achievers Award 2021, 22, 23, more than 15 publications in reputed journals, conducted several training programs at ILSS Faridabad. Especially this is a monthly training or bi-monthly training of the laser enucleation focused, and many have gone there, including our team. Dr. Rakesh has gone and felt that it is very useful. Conducted several training programs, mentored more than 200 urologists in HoLEP and RIRS, operated in live workshops many places. I can say that he is one of the very good understanding. He has very good understanding of the anatomy and able to do the enucleation very well. Taking his last 6 months of experience, who has first used 160 watts in probably in India, I invited him for this talk. Tanu sir, thank you for joining the Pure program. Over to you.
Thank you, sir. Thank you for your very kind introduction. And it's always a pleasure to be on this channel. I will try to do justice to this topic. And majorly in my talk, I will be sharing my experience, which is with my laser. We have had a 150 watt laser for 2 years now, sir.
Okay.
Completed in...
Little louder, sir.
Yeah, we completed 2 years in August this year.
Yeah. Oh,
We
great.
have this 150 watt laser since 2 years. And initially, I also had my apprehensions whether to go for higher watt or not. Earlier, in our earlier machines, we used to decrease the setting near the sphincter. So there was always a worry what higher wattage would do, whether it would cause any harm to the patient, whether it would cause any harm to the laser fiber or the machine. And after doing about 60 cases in my usual setting, I ventured into high power settings. And once I started doing that, there was no looking back. Now anything more than 100 gram, I always go for the 140 watts setting. And majorly, I will be giving this talk through my experience.
Yes, sir.
So talking a little bit about the background, we know that enucleation or HoLEP is now considered the gold standard for surgical management of BPH. And standard holmium power settings are 20 to 120 watt. This is what the standard holmium machines that were available till about 2 or 3 years ago. And then came in the high power machines like 140 to 160 watt, what Chandravan sir was talking. And these are now available and they are available in India. So, what is the key question? Do they offer any true clinical advantage? Is it just a gimmick whether one should go for a high power laser or not? Because if you want to do just a enucleation, you can do even with a 60 watt. But does it have any advantage to go for a high power laser? So we know about the physics of holmium laser. It's a pulsed laser with a wavelength of 2140 nanometer. It is absorbed by water. That is why there is a precise cutting with a shallow penetration of 0.4 mm. The parameters we measure are the energy and frequency, and when we multiply them, we get the power of the laser that is being used. So high power enables higher ablation speed and stronger coagulation. This is believed, and let us see further what happens. So how did these evolve? Earlier, the laser machines that came in were 10 watt, 20 watt, 35 watts. These were the earlier generation of laser. What you see on this side of the figure, these are the cavities of a laser. As you go on adding cavities to the laser, the power increases. So maybe a 20 watt laser may have one cavity, a 40 watt will have two cavity, a 60 watt will have three cavity. It can be 20 to 25 watts, and depending on that, the power goes up. So 100 to 120 watt was very widely adopted and had good outcomes. I used it myself for about 10 years. I used a 100 watt holmium laser. That's what I learned my RRS and HoLEP on, and I was very fond of that laser. And we used it to a study machine. And then came in the 140 to 160 watt lasers, which are the latest high power platforms like Jenner Surgical Hopeless EPS model, potent 160 watt laser, and Quanta 150 watt laser. And when I talk about EPS, EPS means enhanced power setting for optimized pulse energy or frequency. This particular setting is available in Jenner Surgical, which I am using. So these are the currently available more than 150 watt lasers, holmium lasers in India. This one is the one from Jenner Surgical, the multi-pulse Hopeless model. This is what we have at our center. The center one is the one from Quanta. It is a magneto litho 150 watt. It is a holmium laser, but the way they have made the frequency, it behaves like a thulium laser. That's why some people tend to believe it as a hybrid laser because it gives you the effect of a thulium fiber laser, especially in stone. Now, this is the 160 watt laser from Potent, which is being supplied by FutureMed in India. And I have had the opportunity to use all the three lasers. And I should say that I am pretty happy with the working of all the three lasers. The biggest benefit being that they work fine without shutting off during a case, which is our biggest worry when we are using a sensitive machine like a holmium laser. So this is what we have at our center. This is Dr. Sumit and me, our team. We have the Jena 150 watt laser. This was the first 150 watt holmium YAG machine of North India and the second of India. And we have been using this and we have been using the EPS concept, which is the enhanced power setting, which allows high pulse energy and frequency, which gives a scissor-like effect for tissue dissection. We will come to this again. So Dr. Swan Piche is the person who is the man behind EPS setting in this laser. He had this laser and he thought how I can make use of it better. So he did certain experiments like this particular one. This was he had presented this in WCE back in 2015, about 10 years ago. So what they did, they kept a graph paper and over that they put some sand and they fired the laser. They tried to see how much distance the sand is displaced. And if you look at these are the ones on the left side of the screen are the ones with holmium laser. The ones on the right side are with thulium laser. So with holmium laser, as the energy was increased from 0.5 joules to 3.5 joules, you can see that with 3.5 joules, a bubble of the displacement was of 34 millimeter. That means a larger bubble is created, which when it bursts, it the energy is transferred to a longer distance. And when it was compared to the thulium fiber, again, on increasing the energy to 3 joules, the distance displaced was 33 millimeter. So these were the results from his study. They studied three things: the mechanical effect, the thermal effect, and the punctual accuracy. They also used some animal's liver, and they fired the laser on that to see the thermal effect. So when they studied the mechanical effect, they mentioned that the pure mechanically dissecting blow effect or a scissor-like effect reaches an effective distance of 34 millimeter at 3.5 joules with the holmium laser and decreases with lowering the pulse energy to 15 millimeter at 0.5 joules. This is what we saw in the figure. And this effect is independent of the frequency. Whether you increase the frequency or you decrease the frequency, the size of the bubble or the displacement is same. And there is no macroscopically relevant mechanical effect with the continuous wave thulium laser. So when it comes to thermal effect, the coagulation or vaporization were seen at very small distance and with the holmium laser, and they were proportionally related to the total beam power. That means there was not much of a thermal effect despite our worry. And then comes to the accuracy or the cutting precision. It was seen that the accuracy or precision of holmium laser, it increases by increasing the frequency because continuously the waves are coming, and that's how the cutting precision it increases. However, in the thulium continuous wave laser, there was no change even with increasing or decreasing the uh, frequency. So that is why in EPS setting, we use high energy and high frequency. Thereby, we get, as you can see in this figure, like the effect of a scissor. When a lesser energy is used, a smaller bubble is created, the little amount of tissue is dissected, and when you lose more energy with more frequency, again, a larger scissor-like effect is created, more amount of adenoma is dissected of the capsule. And when we go to 3.5 joules, even more amount of adenoma is dissected. So that is the principle behind using a high power holmium laser. So that you dissect more grams of tissue per minute, thereby increasing the speed of enucleation. Why do we want to do that? Because we know that one of the reason of whatever complications like stricture what we get in enucleation is because of the time we stay in the urethra. So my goal has always been to decrease this time by improving my technique and by adopting to techniques like EPS HoLEP, wherein I can do a faster enucleation, and that's how I bring down the time of my per urethral time and thereby decreasing the rate of stricture formation. Now I will just show you some of the cases we have done. Like this particular case, you can see so much tissue. This is a 200-gram prostate, and we operated with this setting. See, this is the EPS setting, 140 watt, 3.5 joules, and 40 hertz with a short pulse. Of course, we can change this to medium pulse also. And coagulation, we decrease the frequency to 30 watt. And just see, we could do this 200-gram
Sorry,
prostate
sir,
in
frequency
50.
reduced to. Sorry,
Sir,
again, repeat the setting for the cutting and coagulation, sir. Repeat, please.
Sir, 3.5 joules,
0.5 and
40.
40. So
So
it
it comes to
becomes
140
120,
watts.
130.
140, sir.
3.5 and 40.
Yes, sir.
What
So
about the coagulation, sir?
coagulation is 2 joules and 30 hertz, sir. Coagulation is more of a function of the frequency. The idea is to, even you can get the same energy as enucleation, but you should decrease the frequency and you should increase the pulse width or the pulse length of the pulse. So here it is a long pulse. A long pulse will always cause coagulation. A short pulse will always cause dissection.
Okay.
That is why having two pedals helps. You can have two pedals. You can have different settings on each pedal. Now, in
You have two pedals in Gina?
yes, I have.
You have two pedals in Gina?
Yes, sir. Now all the lasers are coming with two pedals, sir.
No, all lasers are coming with two pedals.
Yes, sir.
Oh, great.
Even I have seen one with three pedals also now.
For what, sir?
I don't know. It is still in developing stage, sir. They are trying to.
Okay.
So all pedals come with two lasers. All lasers come with two pedals. The yellow and the blue pedal will be there, and you can choose the setting. Now, in this particular case, it was a 200-gram prostate, and you can see that we could finish enucleation plus morcellation in 51 minutes. Anybody who has done decent amount of enucleation would know that this is quite fast. Two more cases. Another 150-gram prostate here. This is, I think, around 250-gram. So very large prostate, same settings used, and you finish the case quickly without getting tired. In other case, you can see a full chamber. This chamber is about 200 gram or 200 ml. So when a chamber is full, that means about 200 gram tissue is there. So you can see 57 minutes, 50 minutes. This is 150 gram. So that is the main advantage. I'm sorry, because of some personal issue, I could not tabulate the entire data, but I've just brought in some cases so that I can show you my experience. Now, these are two more cases. So another way I add speed to my cases is by doing on block. So most of my cases I do a on block enucleation, which is very fast. So when you add high power to on block, then it becomes much faster. So here we have enucleated the tissue, and I'm just trying to show you, these are just the enucleation times. See there, that one was a large prostate, 47 minutes. No, sorry, that above one was after moscillation and lower one is after enucleation. 32 minutes enucleation time and 47 minutes complete procedure time. So most of my cases are now done in less than 1 hour. So very comfortably, I can come in between my OPD. I can do a large prostate also in 1 hour, and I can go back and resume the rest of work. So I will come to some videos. So this is an unedited video wherein I have not split the clips and I have not edited them, except that it is playing at a 2x speed. Now, when I say it is playing at 2x speed, if you see here, this is a 8 minutes 50 seconds. So roughly 9 minutes video. That means the real time of this complete procedure was 18 minutes. So this is a 70 gram prostate. So as usual, we start near the Veru. So this is I'm doing a on block technique. I will not be giving any 5, 7 or 12 o'clock incisions. I start at the Veru, I create a plane, go deep to the capsule, and I extend. This is something I've been doing recently. I extend it to the sides like a mustache. In this area, you will always see a little bit more bleeding, but that will settle gradually. So you try to go deep till the capsule. Once you reach the capsule, you become parallel to the capsule and you divide the fibers. Sir, I hope you can appreciate the capsule and
Yeah. I'm able to see that. I always start like this, so I'm understanding better.
yes. So now we turn the scope and we give the 12 o'clock marking.
Somehow at this point, homium,
Yes, sir.
uh,
I will stop this. Yes, sir.
at this point, homium, the vibration comes so much while it is activated. Unless you stop, you don't know where you are cutting.
Sir,
Fine.
it's
Only at
not.
12 o'clock, I am telling.
Yeah. So the issue is that you can see this in this, it's not vibrating much. Issue is that when we are near the apex.
Vibration means some foggy appearance will
Yes,
be there.
yes,
When you
yes.
stop only, you can see how much depth you have cut it.
Yes, sir. Some juices of the prostate, they come out. And because the irrigation is very less when we have turned the scope like that,
Right,
that's
right.
why we have to dip and then come back again.
Yeah,
So
yeah.
some water comes in and the vision clears. And gradually, as we reach the
Yes, also.
capsule, one of the trick of knowing whether you have reached the capsule or not is that the vision clears. See, I dipped and I went back there.
Correct.
So you go up till the capsule. One thing I would like to tell the beginners is don't get scared of bleeding. People get scared of little bit bleeding and then they worry and then they get into further worse plane and or they have to convert. So now I've given that 12 o'clock incision. Now I'm giving the apical release. That means I'm separating the sphincter from the adenoma. First I did on left side, now on right side. See, this is the reason that on block should be done after a certain level of experience, because initially your vision will not be that great. But you should know what you are doing, where you are doing. So once we have given the incisions, we reach the capsule. And then just like what we used to do in our open prostatectomy, we keep working on the capsule and dissecting all around. So what I'm doing is I'm in this, going into the plane, going to the capsule and then dissecting all around. I will just forward a little bit, sir. Otherwise this will.
130, 140 watts you are using.
Yes, sir. This is 140 watt. See, once here I'm creating the roof and I've reached the bladder neck also, and I'm going even to the opposite side. Wherever I'm getting space near the capsule, I'm just dissecting there. You are asking something, sir?
I'm asking that the amount of the tissue dissected with one sweep is very high here.
Yes, sir. Yes, sir. Definitely.
High means large amount of
Yes,
chunk
sir.
is getting separated. If you are in wrong plane, it bleeds. If you are in
That is
right
true.
plane, it finishes fast like this.
So we tend to go sometimes deeper near the capsule also with a high wattage.
Yeah.
It's manageable, sir.
Yeah, management. It's all experience. Once you get that knack of the curve,
Yes, sir.
you are moving very fast and it goes.
This is 2x also, sir.
Yeah, 2x also, correct. That is also a point. Getting fast also.
Yes, sir.
And
We do realize that we are
but
dissecting tissue
one
during
small thing
dissection.
in thulium fiber laser, it causes charring.
Yes, sir.
Here, charring is less, but the capsule and prostate looks little similar. Do you agree?
How, sir?
Uh, of
No,
course,
sir. See,
capsule
the
is white,
capsule will always be the silvery transverse fibers, and the
prostate is
fluffy part will
floppy.
be the adenoma.
Huh?
The
Prostate is,
fluff, the prostate will be fluffy, the adenoma will be fluffy
yeah,
like cotton wool, and
yeah,
the capsule will be silvery transverse fibers like these.
yeah.
So we do realize during the procedure that more amount of tissue is being dissected, but actually we realize most when we have finished the procedure that it was so fast. As a habit, now I look back at my timer. My staff knows that they have to start the timer, and it is so satisfying that I could finish a procedure like enucleation so fast. It is beneficial for the patient. It's also beneficial for the doctor because in enucleation, you are continuously staring at the screen and you tend to develop dry eyes and all those issues and fatigue. But if
Yeah,
the
yeah.
procedure is faster, definitely you will be less tired and you will be fresher for doing more cases in a day. Otherwise, you go after a very large, this is still a small gland, but when you go to OPD after a very large gland, you will be tired and even your
Tired, you will be
attention
tired.
span won't be
In
like
fact,
usual.
that is the one reason sometimes I say that please let us go to URP and then come out. Correct.
Yes, sir.
Even if the stand is not in front of your eyes, it is really
Yes, sir. And you have to keep the monitor right across.
right.
It's also good ergonomics.
Yeah.
So just a mucosal flap and the enucleation part is done here. You can see the veru, you can see the sphincter on both sides. At 12 o'clock, some amount of tissue we always leave because that's where the bulk of sphincter is. And now I'm doing the hemostasis.
Vibrating. Generally, you don't use TURP loop, na?
No,
90%
sir.
इससे manage हो जाता है.
Yes, sir. Yes, sir. Very rarely, and I use loop.
Very rarely you will use loop.
So you can see that initially there was some reddish and all that, but once the enucleation is complete, it's absolutely clear. Whatever more required, we can do the hemostasis.
This is the area floor. It goes a little deeper, na sir, always.
Sir,
But
yeah,
immediately correct
you
it.
have to correct it. Whenever you are going deeper, you have to
Yeah,
realize it.
there.
Yes, sir. And you have to correct it.
Yeah.
Capsule is also not one layer, sir.
Yeah,
It's
one layer,
two,
correct.
three layers.
Unless we go deep, we don't understand how much front we have to come.
Yes, sir. So that's the adenoma. The whole
I
thing
will
is
ask two basic questions, sir.
yes, sir.
When you make incision all around,
Yes, sir.
you are going right side, left side.
Yes, sir.
You are doing N block.
Yes, sir.
Do you make clearly my question? You have to understand to answer, sir.
Yes, sir.
Do you make shallow cuts at each clock 4-5 times, 10 times, and then go to the other clock? Or you will get cut one layer all around, then one layer all around?
Sir, are you asking at
You are
apex or
understanding my question, sir?
is it at apex that you are asking or for the rest of
Or
the gland?
anywhere in the round the clock,
Yeah.
do you make multiple cuts in between 9 and 6? After that, you will go to 9 and 12, or you will make less shallow all around.
So when we go from below above and above below,
Sir,
it is not possible that we are always in the same line. One from while from coming above,
you
we
will
might
be,
be
I mean to say, you will be connecting both the planes
yes, sir.
regularly.
Yes, sir. You have to connect at these two places. You might be a slightly different depths.
Yeah,
But
yeah.
literally, when you join them, you have to smartly see which one is less deeper, and we
Yeah.
have to follow that plane. If you go to the deeper plane, then you can go on going deeper and deeper, which will lead to more bleeding, which is not required.
Okay. Okay.
So this case is done, sir. We are done with
When
the.
you do on the right side of the patient, that
Yes,
means
sir.
when you are using your right hand towards the left side of the screen, you are understanding, sir?
Yes, sir.
Right lobe, your hand movements will become
Yes.
little awkward and you have to stretch on the penis to the opposite lithotomy position. Do you
Hmm.
think that extend the lithotomy position should be wide? One question. Second question is, when you are traveling between 7 o'clock to 10 o'clock, you feel
Mhm.
little difficult whether to keep the laser fiber at the 12 top or bottom, whether you have to do a forward movement or reverse movement. I hope you are understanding my question.
Yeah, I'll take one by one. So first thing is about the position. A extended lithotomy is always preferred, or a wide lithotomy. And more important is the sheets that are hanging. They should not be just because that is where it gets stuck.
Okay,
And many a times we really have to go much laterally. See, whatever we are seeing in the urethra is just the obstructive part. And laterally, how much it is extending can vary.
correct.
Many times it goes really laterally and we
Very
really have to
literally.
bend. But then enucleation will be good only if we are on the capsule. So we have to make that effort. We have to bend that much. If the foot is coming in our way, we have to tell the assistants to change the position of lithotomy and make it a little more extended.
Okay.
That is one thing. Now, regarding the 7 to 10 position, you said which position of the fiber is beneficial. So, if you
Usually
see my,
people use in the beginning part of the surgery
yes,
laser fiber at 6 o'clock position, like
correct.
floor.
Yes,
Everything okay, okay. Suddenly they will turn it up and the entire surgery they do it with the clock at the laser at the 12 o'clock position.
yeah, it varies how you have been trained, sir. I generally don't do the entire surgery with it at 12 o'clock position, but because we are using a 30-degree telescope,
Yeah, yeah, yeah.
idea is to see the correct plane. I want to see the capsule, I want to see the adenoma.
Yes.
Whatever angle I have to give, if I am at this position, my fiber will come out at this position so that I am firing right at the capsule.
Okay.
So most of the times, in fact, it is parallel to the capsule.
Okay.
We just run parallel to the capsule. Many people I have seen, as you said, once they turn it to 12 o'clock, they do the entire procedure by 12 o'clock position.
12 o'clock.
So one idea behind that, especially near the floor, is to avoid undermining.
Yeah, yeah, yeah.
So that is the main reason. For me, I tried just to be more careful near the bladder neck and I make J-shaped incisions. I think we'll see in the next video how I work near the bladder neck.
Sir, one more question, sir.
Yes, sir.
When you use a trigger type of mechanism, people say trigger is not useful. And
Hmm.
in fact, they want to like Gomencha, he uses like pencil
Hmm.
where he doesn't want to use front and back movement at any part of time. Do you also, he uses only tip of the laser fiber?
Yes, sir. Actually, the to and fro movement is hardly used, hardly.
Hardly used.
Only towards the end of the enucleation of a lateral or median lobe when it is hanging just by a mucosal
Okay.
stretch because the strip. That is when we just push it with that. Otherwise, it's not required actually. But it's just that feel of having the
During
thumb.
coagulation time, it may be useful, sir.
No, sir.
No.
Because usually these are venous bleeders that are bleeding, and we have to go close with the telescope, with the flow being there. Only
Hmm.
then we are able to see it and pinpoint with the laser.
Okay.
If I try to keep my scope far away and try just to push the probe ahead, I will not see where I have to fire, which is very dangerous,
Yeah, yeah.
especially near bladder neck.
Okay. Got the point.
So this is a 188 cc prostate, sir. It's quite a vascular one. First, I showed the clean case. Next
Yes.
case, you'll see a little bit more bleeding. So I did this using a modified two-lobe technique, which I use for anything more than 150 gram. So what I do in a modified en-bloc technique is, modified two-lobe technique is that I take out the median lobe as one lobe, and the rest of the two lobes I take out them as en bloc. So median lobe is one piece, and both the lateral lobes come out as the second piece. So we start the case like a usual three-lobe technique, wherein we make a 5 o'clock and a 7 o'clock incision. So this is, you can see and one thing about these very large prostates is one of the most bulky part of these prostate will be the median lobe. So that has to be taken care of well initially. so that it goes into the bladder and some fluid flows around the fossa so that you have a better vision. So as usual, we make an incision near the veru. Some bleeders will be there. You go deep till the capsule.
Some people say that HoMEM is not a coagulative laser because it is a correct plane, bleeders will not come. But when
Correct.
the bleeders come, it is difficult to control the bleeding, large bleeding with the HoMEM. Is it correct?
It is correct, sir. You might have to spend a few more extra seconds, but once you learn the technique, so now I'm giving the 5 o'clock incision
Yeah,
from a bladder neck till this point.
correct. Very nicely it is
So
correct.
this is why we keep the aiming beam on so that we can pinpoint now that bleeder and coagulate it by staying it on it for 5 to 6 seconds.
Okay.
So now we are deepening that plane, sir. You can see the capsular fiber already.
Yeah, yeah.
Now, as I said, in
Be
every
fast.
large prostate, one of the most bulky part is the median lobe. So what
Uh,
we do is that as we are deepening this incision, we tend to go medially as well. So
yeah,
that we do a lot of dissection of the median lobe here itself. And this is another way in which I prevent the undermining. Now I'm giving the 7 o'clock incision. This is an edited video.
yeah, yeah.
So some parts are there. So 7 o'clock incision given and we deepen it. And same thing what we did on right side, you can see we are sort of enucleating the median lobe also as we are doing it.
Correct.
So if I'm in the right plane, the bulk is immaterial. This might be a 300, 400 gram prostate also.
Yeah, yeah.
And you can do it. So now these two incisions are joined. Only little bit remaining to be removed.
And that's all.
Yeah. Some part near the bladder neck. So the bleeding that we are seeing, most of it is from the tissue itself. The one that remains is to be enucleated. So there's no point spending too much time on coagulating it unless it is hampering your vision. So you have to be careful about the ureteric orifice in these large prostate. The last part, always go and see the orifice and then only you start cutting. First, I saw the left ureteric orifice.
Are you doing the right lobe first?
No, this is the median lobe, sir.
Median lobe, still you are
So
doing.
modified two-lobe means I take out the median lobe as one lobe. This is your left side and that's the right side.
Yeah, yeah.
So I take out the median lobe as one piece and the rest of the prostate as one piece.
One piece.
So that's how I make it
That gives
modified
some
two-lobe.
space for the lobe to accommodate.
Sorry, sir.
That gives some space for the lobe to accommodate inside.
Yes, sir. When the median lobe is gone, the flow is much better.
Yeah.
It becomes much easier. If you try to do whole thing on block, especially the median lobe enucleation is much difficult. The last part of the enucleation becomes difficult. You tend to go deeper. So very large prostate, I try to do that. I have seen all these
As a
large
matter of fact,
prostate.
there is no greatness in doing en bloc with such a large median lobe, na, sir.
Yes, sir. There's no greatness, sir.
There's
I don't
unnecessarily
prefer
you
that
have
anymore.
to
Now we give the 12 o'clock
follow
marking,
clock. It's coming nicely.
the distal limit, and you go till the capsule. These are the juices that come out, which we were talking about,
Yeah, yeah.
the whitish things. And then we start walking towards the bladder neck. So this part, now I do the two lobes like a on block only. See, we have reached the bladder neck, sir.
Yeah, yeah.
All these very large prostates, they will be more congested and they will have these varices like bleeders near the bladder neck. So some people tend to leave it attached till the end and then they divide the bladder neck. I like to do it initially only. I know that there are bleeders, but they are venous bleeders and they stop by the time I start enucleation, emulsion. So now I'm doing the apical release, first on left side.
Sir, even in such large glands, even beyond the veru, there will be verumentanum prominence will be there.
Yes, sir.
Beyond that gland will be there.
Yes, sir.
Somehow most of the people 1-2 centimeter they leave the mucosa and then they make curve underneath it.
Yes, sir. So we have to go till where the maximum contour is there.
There's some mucosa leaving behind any reason, or you can cut the mucosa
No,
also.
it's just that I just follow, like you can see here
Yeah.
also.
Yeah. Yeah.
I've gone till the maximum contour. See, I've slid much more vertically than the wire. So
Okay.
then you try to get into the correct plane. So it is like how we used to do in TRP only. Once we have made this incision, then we get behind the sphincter and that's how we enucleate it. Now, this is the advantage of holmium laser. You see these nodules.
Yeah. 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 It is lifting like it.
In Yes, sir. In thulium fiber, we cut through these
Yeah. Yeah.
nodules.
Yeah. Yeah.
So this is one of the big advantage I feel. So we go from below above, then we come from above below, and we just find the capsule. We go on working on the capsule and enucleating the adenoma. There's a bleeder there near the bladder neck. So here you can see, sir, I'm using the laser beam to pinpoint on it and coagulating it. You will have to spend a few extra seconds, but it can be done. You can see the vessel getting charred there.
Yeah. 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 You have shown nicely.
So now again, we come back to the capsule. At places you will be deeper, you have to realize that you are deeper. Now I've changed the plane here. I've changed it to a more superficial plane than the earlier deeper plane. Best thing is to come from defined to undefined area, whatever incisions you have given initially, and that is where taking out the median lobe helps here. We can always come back to the floor and then start towards laterally because we have our capsule well defined in the floor.
Yes.
So definitely high power adds good speed,
Sorry. Ah,
and we are able
the
to.
speed is very high.
Yes, sir.
But the only worry is if you go 1 second also wrong plane, it may raise or deepen.
That is true, sir. With great power comes great responsibility.
Yeah. Yeah. Yeah.
So with
Like high
after
speed.
I also started using high power only after 60, despite having the
But
machine. See, I've
that
gone deeper
message,
here.
that message, if you give, I am very happy that the day you take for because you have money, if you take high power and start doing very fast, there is a chance of perforation.
Yes, sir. So we do go deep. We go deep in 100 watt also. We go deep in 60 watt also at times. Generally, the perforations with holmium are not very deep or with any laser
Yeah.
compared to a TORP wherein we are scooping the tissue out.
Yeah. Yeah.
The
Yeah.
trouble that will give you
You can
is
go
that
few
you will have,
millimeters and recorrect it.
yes, sir. The
Correct.
trouble a perforation will give you is that you might open one of the smaller or sometimes even a major sinus.
Mm.
So if that happens, you have to recognize that. And before you start the morcellation, see, I've gone too far there. So
Yeah.
before you start the morcellation, you have to take the ball electrode and you have to do a good coagulation
Coagulation.
so that you have a good vision.
Great.
So now on the right side, we are working from below above and now from above below. Going on enucleating the right lateral lobe. That's near the bladder neck, the vascular part. And some more bleeders are there. Sometimes you see this
How
bunch
much time
of.
it took, sir?
This one took about 37 minutes for enucleation, sir.
Great. How many bottles roughly for 100 gram?
Sir, our that one jar is about 200 gram. That
No, a water bottle, sir.
I have not counted, sir. Sorry.
Five, six.
I think that would have been a good measure.
Uh,
I think that would have been a good measure, but I have not counted. Sorry.
Generally, for TURP, we take 7 to 9 bottles. For enucleation, it will become 10 to 14. So,
Yeah, it
how,
must
what,
be.
I think it will be 2, 3 for you, maybe.
No, sir. हो तो जाता है. पानी तो लगता है.
Enucleation, sorry, morcellation will take.
Yes.
The
Morcellation takes
function
more
will be
because.
there.
Yes, sir.
Morcellation is also an art, sir. Any tips you wanted to say?
The morcellation, the vision should be very good, sir. The hemostasis has to be very good. Go to the adenoma, catch it by suction, bring it to the center of bladder away from all the walls. Do not be in hurry. Morcellation should always be slow and steady, especially initially in practice.
Yeah.
Even if you catch the bladder, you should identify immediately and take your foot off the pedal and usually it will be just a mucosal perforation. So that is the sphincter area, sir.
Correct. Nice.
And now I've inserted the resectoscope. This is 33 minutes, sorry, enucleation, sorry, and 35 minutes morcellation. So you can see bladder orifices are fine. That's the left side orifice. That's our capsule. Few clots are there. No need to worry about these clots. In such a large prostate, I do start irrigation. Most of the times, otherwise, I don't start. So that's the sphincter and the Veru area.
Very good. Excellent.
So this was our largest prostate till date. We use EPS in this 350-gram prostate. I had presented this video in your pure group also, sir.
Yeah.
In
Sure.
the and so what I did, I could not tabulate the data as I said, but what I did, I always take these images at the end of a procedure. So I picked up 10 such images and I put it in ChatGPT, and it made a data for me that how much time I have taken for the last 10 cases. And you can see, sir, it varies from 17 to maximum of 57 minutes.
Great.
And this includes a 250-gram prostate. So that we are able to do it well within 1 hour. Now, coming back to some data, again, this data is from Dr. Swan, who is the, I would say, inventor of this EPS setting. He tried to see how fast the residents learn it. And he gave them different settings, and he found that with the EPS setting, the learning curve was shorter on an average of about 9 cases.
Okay.
Then there is some clinical evidence of high-powered laser. The study from Yildiz et al. 2019, 140-watt laser. They studied 540 patients, and they said the enucleation efficiency comes to about 1.72 grams per minute. With a good improvement in IPSS and Qmax. This is equal to any other setting with a low complication rate. And there are other studies also of 100 to 120 versus 140 watt, which show similar outcomes with minor time reduction. So what are the potential advantages of a 160 watt or anything more than 150 watt? The enucleation is faster, especially for a large prostate. You decrease the complication rate, you decrease the time, surgical time, you decrease the anesthesia time, you decrease the surgeon's fatigue and tiredness. Hemostasis is better, the bleeding risk is lesser. That's mainly the advantage of enucleation per se. There is a reduced operative time, so the OR efficiency increases. You can do more number of cases in a day, and it may also shorten the learning curve when combined with EPS, which needs to be studied further. What are the potential challenges? First thing is the fiber burn back. With any high power, the fiber burn back will be more. So your consumable cost will go up because you will end up using more fibers if you are using this. Although I must admit, with my current machine, still I am able to use the fiber for many cases. Then there can be increased thermal energy. There's a theoretical risk of capsular damage, and more importantly, be very careful with those large median lobes which are extending towards the ureteric orifice, because if you are anywhere close to the ureteric orifice, you can damage the ureteric orifice. So when you're using high power, be very careful near the ureteric orifice. Outcome depends more on the surgeon skill than the machine, which is the most important thing. The surgeon operating is more important than the machine or the energy that you're using. And there is a higher capital cost of 160 watt or a 150 watt platform. So these are the challenges. There are some evidence gaps, like there are few direct trials of higher wattage versus 120 or 100 watt. There are limited long-term outcomes for 150 to 160 watt. Cost effectiveness data is lacking, and we need standardized reporting of enucleation efficiency and complications, which is not there. So to summarize, high wattage holmium laser of 140 to 160 watt improve efficiency, especially for large glands. EPS and HoPlus, they improve training curve and OR efficiency. Functional outcomes are largely similar to low wattage symptoms. The evidence gap I mentioned, that further trials are needed. And power is a tool. Surgeon techniques remains more critical. These were the references. Thank you, sir.
Thank you, sir. Few questions. Can we close the screen, sir?
Yes, sir.
Yeah. So quickly, 5-10 question, practical questions I want to ask. Does high wattage laser can be used with any size like 17 has come, ultra, mini, HoLEP, 22 is there, mini HoLEP, and
Yes.
26 is there HoLEP. That doesn't make any difference, no, sir.
Yes, sir. It can be used with any size.
Any size. What is your preference in little short penis and short urethra? If the 26 is not going freely after OTs,
Yes,
uh,
sir.
uh, immediately you will change to smaller, sir?
Yes, sir. I don't have a 18 French so far. I
Yeah,
do have a 22 French system. But the thing is, if there are some urethra which are not that accommodating, which we can either dilate by Otis at same time, or if it seems narrow, then we can put in a catheter and coming after 2 weeks. But I have seen urethras with short, small penis and small urethra. I don't think we can dilate them by any means.
yes, yes, sir.
So what
And
I
there is
have
high
done,
chance of stricture if you do forcibly.
yes, sir. So what I have done in two such patients is that I have used OIU sheath with the laser working element, and I have used the Alkan cannula for outflow suprapubically.
Yeah, yeah. There's
So that's how,
something should be reduced in size so that you are safe.
yes, sir. And then you have to do the morcellation also suprapubically, which is difficult, but you can
At the
manage.
end of enucleation,
Yes, sir.
the mucosa is at the level of the sphincter. Sphincter is contracting nicely, but the mucosa is disrupted because of XYZ reasons.
Yes, sir.
Increased chances of stricture formation? No.
At the level of sphincter, sir, bulbomembranous area, you are saying.
Membranous, not after. See, when you are going retrograde,
Yes,
first
sir.
it closes. After closing, you open at the level of Veru, after the sphincter,
Yes,
retrogradely. If the mucosa is completely disturbed, is it
yes, sir.
okay? Sometimes when you do
So,
movements, this, that,
yeah, so that is the reason we have to use Otis. That is the reason in fact, I put in the Otis inside the till the bladder. That's my own thing. But anyways, we need to dilate it whatever way we use, and need to use a lot of lubrication.
lot of lubrication.
I use at least two jellies in every enucleation, sir.
Okay.
And off late, I started using some steroid cream also over it, which does not have any scientific basis probably, but I have seen some senior surgeons doing it with TURP routinely.
Sir, one more question, sir.
So,
Everybody nowadays are starting incision, whatever lambda or horseshoe, whatever incision at the floor,
yes, sir.
they are extending to the roof at 6 o'clock and make a landmark
Hmm.
horizontally uh, at the 6 o'clock. Previously, they used to come proximal to distal at 12 o'clock,
Hmm.
deepen it, and come up to the Veru above, and then take turn on either side. So you are understanding my question.
Yeah, I'm understanding, sir.
Making mucosa release apical, whatever apical release you say,
Yes,
horizontally at 6 o'clock deeply
yes, sir.
is now lot of people are showing.
Yes, sir.
I have seen both. So what do you follow now? Always you release?
Uh, yes, sir. I always release, even though I am part of a paper myself, which showed that apical release does not offer any advantage as far as incontinence is concerned. But in my practice, my own practice, I feel it has made a difference. And there are three predictors of incontinence. I mean, with patients who are more at risk. One is patients with long-term diabetes. Second is very old age patient, and third is very large glands. These are the patients I would always counsel that you have more chance of incontinence. But I would admit that sometimes it's difficult to say the patient we think that very less sphincter, maybe some we have gone beyond, and they will not leak at all. And the patient in whom you think that, yeah, everything is preserved nicely, they tend to have some stress incontinence. But it all recovers.
Very
It's
obese
all
patients also.
temporary stress incontinence. It responds very well to Kegel's exercises. And till date, I have had one patient who required a tape. Regarding the technique, sir, I feel what I have done and what everyone else has done is we follow a mentor, we see how they are doing. Initial cases we do by their techniques, and then we develop our own techniques. I have seen in one same surgical workshop, the person who's attending tends to get confused because three consecutive cases are shown by three totally different techniques.
Hmm.
So in my workshops and in my this one, I try to show classic three-lobe technique as much as possible because that is the most important. That is what all of us should learn. That three-lobe technique we should know. After that, we can develop our own technique. Even for on block, I have multiple techniques.
Yeah, yeah. Sir, nowadays, the TFL enucleation surgeons, particularly large gland, when you sweep a little roughly, large amount of gland gets separated and it looks beautiful.
Hmm.
Reason being, one layer of the capsule with all the vessels will be seen so nicely.
Hmm.
They do entire surgery like that and they quickly finish it. It amounts to bipolar enucleation.
Hmm.
But many of the very good enucleation surgeons don't do that.
So, but I think you're talking
I
about
hope you are understanding my point.
mechanical part of the enucleation.
Mechanical part they sweep so
Yes,
nicely
it,
that
it will come
even
out, sir.
it will come out.
Ultimately, we are replicating the our Freyr's prostatectomy. What we were doing with the finger, same thing we are doing either with the scope or with the laser.
But
If you do
one
by
one difference,
finger,
they come antigrade, we are going retrograde.
yes, sir.
So here we cannot use force like finger. Finger is blunt.
Yes, sir.
Whereas here laser retrograde because it's nearer to sphincter, we have to use cutting. That is what logically you people explain, seniors.
Yes, sir. So, especially with holmium laser, what happens is we keep it at a distance. So,
Hmm.
I always tell the best distance is when you see a halo around the beam. So, what is that halo? There's a little bit of hemostasis happening all around that beam.
Yeah,
That is why you go on cutting and you go on doing that hemostasis. If you are very patient, if you
yeah.
follow that plane, your vision will be very good. You will be in the right plane and you'll do a very comfortable enucleation.
But you
If
don't
we
do.
try to cut that short, be in a hurry, we go close to the tissue, cut through the tissue,
Yeah, yeah.
or do mechanical, that is when we get more bleeding and a poorer vision. And that is when we land up in difficulty. But mechanical enucleation can be done, sir. Ultimately, enucleation is enucleation. The results, or especially when it comes to the flow of urine, is because of enucleation, a good enucleation. And I think
No,
that
sir.
is
This is
what
another
all of us
point
should.
here. When you do mechanical, people say that the axis of the urethra at the level of the sphincter gets disturbed, stretched, damaged, and so that a little longer incontinence. See, whatever, sir, enucleation, passing urine more than that, the controversy of enucleation, why even I am afraid is even 5 days of urine leak after TURP. Oh, patient, sometimes they don't go home. They say that I after control only I will go home because they will not have any
So
work.
that is because we have not told them beforehand.
Yeah,
If
yeah.
we tell them beforehand that these three things, I tell my patient that three things are expected. One, they can have some bleeding for some time.
Hmm.
Two, they can have some dysuria, and third, they can have some leakage, which can initially be, they can have wetting also.
Okay.
I counsel them beforehand, so that is a accepted part of the procedure. Most of them will not have it, and they say, "Doctor साहब आपने तो डरा दिया था." But if they have it, they know that they have been counseled beforehand, and generally they don't tend to stay for so many days. And we start them in Kegel exercise. We tell them that it will come down. And then depending on the age or diabetes and all those things, it might take some time or it might come down early, but it does come down. Till date, as I said, only one of my patients has required a tape.
What about,
They have come back to me.
have you seen any fluid which needs to be drained by a drain in extra peritoneal, extra retroperitoneal perforation with high watt laser, and then you correct it after some time by the time fluid seeped out?
So never with this particular laser, sir. Initially in my practice with 100-watt laser, I had, I think, two cases in which we noticed that there was a bulge suprapubically later also, despite the catheter. And we placed ultrasound, there was fluid, we took it out with the needle, and that's known, we didn't have to place a drain. So far, it's never been a hindrance to complete a procedure. Having said that, any doubt at any time, it's better to put in a catheter and stage the procedure, see what is happening where.
Okay. The last couple of questions, sir.
So,
Uh, any clue that bladder neck contracture, honestly, URP versus TFL versus homium, when you make a wide opening, removing all the mucosa at the edge of the bladder prostate junction versus some people say that a strip to be left anteriorly, some people say come inward at the bladder neck and retain the bladder neck, which is very difficult, I feel, for imagination also, because you follow the prostate so well. Ultimately, you make a big opening.
Yes, sir.
Any comment on the bladder neck contracture and how early you incise again with a laser? Two questions.
Sir, I've not had a bladder neck contracture for a very, very long time.
Very good.
Still, when I do a smaller prostate, at the
Okay.
end of the procedure, I give additional 3 and 9 o'clock position incisions. There was a paper in between which showed that there is a decreased incidence of stricture when you give these additional incisions at the end of the procedure. They recommended 5 and 7 o'clock position, but I realized there's nothing there at 5 and 7 o'clock to incise. So I give these incisions which nicely release the bladder neck. And even after enucleation, you will see a wide bladder neck. After these incisions, you see a even more wider bladder neck. In between, I can just say that some of my, I know I might sound biased, but some of my TFL cases, I did see bladder neck contracture. If I have a contracture after laser, I have incised them with cold knife instead of laser, hoping to cause less ischemia and scarring again.
Sir, one last question.
One or two cases, sir, sorry.
Sorry.
One or two cases I have seen where the entire cavity has obliterated. These were those diabetic patients with recurrent UTI. And I have no clear explanation why that happened, but I have seen those synechiae blocking the cavity. Again, in these cases, I incise either with the very high cutting with laser or with the cold knife.
Great. That's a very rare thing to see, rare thing to imagine also. Last question, sir, a little tricky. You have to answer. The TFL at 45 watts is less costly, and the homium laser is more costly, double, triple. In that case, can you pass on the patient with TFL less charge and homium more charge? In a competitive world, if I can do with TFL also with good result, how can we? It's a practical question I'm saying, because a lot of youngsters are buying homium. You know, one surgeon Vamsi, who is my close friend in Hyderabad, does with 35 watts. His favorite settings are there. He may take little more time, but he's logical, and you can charge less. So how do you take? There is no conflict of interest. I'm just asking. India is a country where cost matters, and from beginning, homium enucleation was costly. Initially, actually, did not become famous because of the cost. Now, because learning everybody, because of few teachers, everybody is learning actually, basically.
Yes,
That's
sir.
why they are doing. Previously, only few people like Anil Varshan and Pankaj Maheshwar were doing. After you, Ashish Seni and Manohar have taken up, you created more younger generation. So what is your comment on that? Cost effectiveness of homium versus TFL, does it matter at all?
So there are 2, 3 things to this. Regarding the initial cost. Initial cost, when you are investing in a system, it is the initial cost, be it a 60 watt TFL, 35 watt, or a 100 or 150 watt, whatever. When you charge to the patient, generally you charge as per the consumables or maybe the laser fiber and all. That is one thing. Secondly, I don't think maybe Dr. Vamshi is charging less, and I don't know about you, but what I know, when people charge for laser prostatectomy, they charge for laser prostatectomy.
Yeah.
They don't charge for TFL or HoLEP. In fact, many people write HoLEP
Yeah.
because patient is demanding HoLEP.
Yeah.
So, but good thing is at least we have started doing laser, because earlier when people were doing TURP, some people were still telling the patient we are doing laser. We have to be truthful to our patient. If we are saying laser, we have to do laser. Regarding holmium versus TFL, definitely the enucleation is better with the holmium. There
I
is no
also agree. I
Doubt
also
about that. So if you can
uh,
afford it, I would recommend go for a Holmium. Charges you can decide.
yeah, got the
We
point.
can do. There is no. We are not using any guide wire, access sheath, suction, this that. It's only the recurring cost is that of fiber, which will also give you multiple cases. So we
Yeah,
can be very flexible. I can. I mean, and our insurances have also forced us to learn how to do.
yeah,
To do at cheaper rates also at times. So
so small
I
gland,
think one
large
can be
gland,
flexible about that.
Homi, I think
Uh,
enucleation is enucleation with laser. Overall,
yes,
see it as a surgery enucleation of prostate than
yeah.
individual details, a
One
gross
more,
amount.
one more small point, sir.
Sir,
When you do, I'll talk just about TFL. If you are doing enucleation at 35 watts with a 60-watt laser, it will be much better than a 35 watt with a 35-watt laser. Same thing holds true for Holmium also.
sir.
Low power with a high power machine is works better than a low
Yeah,
power in
yeah,
a power
I got
machine.
the point. Delivery amount of delivery in high power mission for the same setting will be better. Even in
Yes,
stone, I have seen that if you buy 60 watts, if you keep 15 watts,
yes,
it goes very fast.
yes, sir.
But
So,
logical, we don't know. I mean, I used
yes.
to think that if you fill the petrol tank full, probably you go faster like that. There will be a feeling than when the petrol
Maybe, sir.
is less.
Maybe, but then it's not really a low power HoLEP. That's my point.
Yeah,
Anyways, you're investing in the machine.
yeah, yeah,
When you're going for a 60-watt TFL, you're investing more than a 35-watt TFL.
yeah, yeah.
So better to invest whatever best you can.
Higher
Your
watt
pocket allows,
lasers
your
with the tank.
patient pocket
For stone
allows.
also you are using, sir, more cases,
Yes, sir.
stone,
Yes, sir. More we do more stones than this,
more
and we have
stones.
our own good settings for both the pedals. I
Mhm.
use different setting, and Dr. Sumit, who is with me, he uses totally different settings.
Okay, okay.
And we
PCNL
use
also you use laser?
yes, sir. Yes, sir. We prefer Holmium over TFL in PCN also.
Yeah, that is
We like to
100%.
miss, yes, sir.
Even I agree that.
And with suction also, we prefer Holmium than TFL. Well, means these are
Small fragments will form better with chromium than
yes,
put
sir.
together. I agree that.
Yes, sir.
TFL is powder and that's more useful for RIRS. That's a multiple time discussed. There is no doubt about it.
Yes,
So
sir.
I thank you very much for the nice discussion. Very, very friendly discussion. I hope it will be useful. Exactly 150 people joined and went. And good, that's a good number. And it is picking up, sir. Last 5 years, a lot of people are doing enucleation.
You are starting pure university.
Great, great. Thank you, sir.
Thank you so much. Thank you.